but there is no results but there is no results where we are actually comparing it in presence, right? Like an RCT or something, or a more larger sample size being in phase 3. So this alone cannot stand, but this can uh, give a pathway that we can do a phase 3 study further and look for two-arm comparison with standard or the historic standard and estimate the efficacy. Okay, let's go to another. In the above study, the outcome type is, so the phase 2 study which we described, what is the outcome type?
Okay. So what was objective in phase 2 study?
It
Response rate.
was response rate.
Okay. So if the response rate is the outcome, then what is the type of outcome would we call it? Is it a categorical binary, categorical ordinal, continuous, or time to event? Okay. It's a response rate. Binary?
Yeah. So it is categorical binary because what response we would be having, we might have based upon this complete response, partial response, but later on we are going to have a definition, right? That complete response and partial response is considered as response, standard disease or stable disease or no response is considered as, or progression disease is considered as no response, right? And then we will take the percentage of yes and no, and we will say this out of 100 patients 70 had response, so that is the 70% we achieved as compared to 30% no response. So this can be
I think
considered as categorical binary.
yes. So I think that is a very good point to touch it, and there is a always get confusion. So there are two portions in these questions basically, as Akash asked. So response rate, once you are saying about the response rate. So first of all, how you are entering data for response rate. So for individual level, each patient level, once we are entering data response rate, we are going to enter data as yes or no. That's mean response occur or not occur. So in that sense, response would be considered as binary data, yes or no. Okay. But the second point comes as a, when the study objective, study abstract say that we are going to see the response rate. So in that sense, how we are going to calculate? So for each patient, like we put the response occur or not, response seen or not, so like yes or no. So let's say then 100 or 200, whatever the number of patients we are calculating response or yes or no, that should be converted into percentage. Once you convert it into percentage, then it's called as a response rate. Out of, let's say, 230 were having response, so that is a 15%. 30 out of 200, that in 15% response rate would be achieved. So there is a two part, and once you're presenting into percentage, so it could be between 0 to 100, and that's a completely different ballgame. But while you are calculating or entering data, that should be 0 and 1. Yes.
Yeah. So let's go to another question. Let's finish it early so we can start. So in phase 3, we included control arm as well now. So that was phase 2 study. We included a control arm and we did the phase 3 study. Is it now more confirming results for efficacy? Everyone has said yes. I guess 50% have said yes. As we have answered in our second question itself, like more confirming results are required than a phase 2 single arm study to make it more efficacious and to establish experiment treatment as more efficacious. So yeah, we would require some more evidence that can come as a phase 3 with RCT type of study design. Say anything from your side?
No, perfect. Yeah.
Yeah.
No.
Let's go to next question then. Now that we have two arms, the responses between the two arms can be compared using which test and represented as. So here we see more is gone to t-test and mean increase in response rates. we have options of chi-square and representation as percentage increase in response rates. Another is chi-square and percentage change in response rates.
Okay. So background that how we are going to present these tests, that is matter of concern. So if you are going to have, so what is your outcome here, Akash?
Here, response rate compared between
Response.
two arms, phase 3.
So how you will present it? So response rate between two arms, which one you will be going for that then?
So if I would be there, I would go in like chi-square and percentage increase in response rates. I can present the table as results in this way. I will compare the rates using chi-square and I will present the percentage increase in response rates.
Okay. And that is the minimal response you are receiving here.
Yeah, that is, yeah. We can do present the change as well, but yeah, we have to interpret it as an increased change.
Definitely, it is not going to be t-test.
Yeah,
So chi-square, either chi-square could be considered, but definitely not the t-test.
yeah.
Okay.
Thank you, sir. We'll go further.
Yeah,
Yeah. In phase 3 design,
is considered.
so here the phase 3 design, which we now made by adding control arm and by checking the responses between two arms, which kind of design it is. Superiority study, where experimental treatment was considered to be better than the control while designing itself. Okay, while designing this phase 3, we decided that the experimental is going to be superior. In that way did we design, or it was designed as non-inferiority study, like experimental treatment was considered to be non-inferior than the control arm while designing, or was it considered equivalent study, like both treatments were assumed to be similar while developing the study itself? These were the three options. So we see like everyone has opted for option one, which is superiority, which is correct. Like when we achieved in phase 2 that response is better, we already knew that response is going to be better. Now I want to do a phase 3 study where the experimental arm is going to be superior than that of control. So while designing itself, it was considered to be a superiority study. Yeah, good. Thank you. Now one more question. In this phase 3 study, so we are just going more into now RCT now. In this phase 3 study, the stratified randomization was applied, okay, to assign patient either into control or to the experimental based upon their gender and ECOG, disease performance, ECOG performance. Why? So one was to have an unbiased result. Another was to nullify confounder effect, or just to allocate patients to arms. So I see it's answer second chosen by more of
Correctly
the
done.
people. Yeah. So here we come across, along with this sessions for TMC Muzaffarpur, we have a GSP program going on, which is launched from today itself, and some of you have already signed up for it, and thank you very much. And this is going to be a very technical but very very hand holding session for having a good practice of statistics in clinical design studies in your research collaborations, everything. So why is GSP required before designing clinical studies? Okay, good statistical practice. Why one should have a good statistical understanding before designing a clinical study? So one is to estimate what estimates are really important to understand that. What can go wrong in establishing this causal relationship, to choose clinically relevant endpoints and optimize patient data. Ideally, all are relevant, all needs to be taken into care while designing any clinical trial or something, because each of these steps helps you decide what is going to be uh, very needful and how to establish your study further based upon the statistics. So all are important, and I guess what estimates are really important. This is really the first one people have noted. yeah, as per the hierarchy, we can give it as the utmost important. So why do you want to learn biostatistics more? What do you want to learn more in it? So this is the tree we have generated. What everyone is more people are looking for sample size creation, linear regression, importance of sample size, biostatistics, same sample size determination, SPSS or R for data analysis, hypothesis testing, ANOVA. So yeah, in all, this is a nutshell of things that basics of biostatistics. Yeah, nutshell of what everyone wants to learn. And these sessions with TMC as well with GSP are made in such a way that all our clinical members would get to know on this and make their studies more powerful enough in the environment of clinical research. Yeah, thank you everyone. Yeah, this was a
Okay.
very engaging session and we got to know more about you as well. So we'll
Okay.
move further with the sessions now. Sorry, thank you, sir.
Akash,
And thank you.
thank you. So I am going to share my screen. So would you try to start, or I will start and then we will go for dashboard?
Yeah,
Okay. So I'm going to start it then. Let me share my screen. Let
okay.
me share my screen. You close. Let me. You stop your sharing. Let me share
Yeah,
my screen.
that's all.
Yeah. Would you see?
Yes.
Yeah. Yeah. Would you start, or I'll go for that? You start then. We'll go
Yes.
for your topic. Yeah.
So the screen PPT is not visible.
Not visible.
So as we talk more about designs today, like last session we discussed about the endpoints, analysis methods to and analysis method to analyze the data with particular endpoints, chi-square, t-test, and everything. Now we are going to more into designs. So we now that already have some information about what the outcomes or the data looks like, we are going to now understand these clinical studies and how the outcomes are used or based upon the outcome assumptions, how the designs flow or the statistical aspects of design changes, right?
Yeah.
So this is what the study design is, and it is way more important in clinical research because before defining any question, we need to understand what kind of design it has to be. Based upon it, its estimates, analysis plan, evidence hierarchy it falls into, right?
Yeah.
So we'll be having this live session and this will also be recorded and the slides will also be shared with you guys. We have quizzes in this and R is shown to do the data analysis. Right now for this session, it is R is not implemented now, but
But
yeah,
background was created with
yeah,
the R and assumptions over there.
yes. So,
Somebody need to be
yeah.
mute.
Can we go to second slide?
Yeah.
Okay. So, during these whole studies, whole session, we are going to discuss all and around with these four studies, right? One is Doll and Hill, which talks about smoking and lung cancer, where they
Yes.
interviewed patients who had lung cancer and they had their controls with another hospitals and they
Mhm.
surveyed it for some period and established some results from. Okay. Then is
And then
ATBC.
another one, ATBC and CARET study that conducted between 1994 to 96, and it was about beta carotene and lung cancer. So if you see that study, there was a years of observational studies suggested beta carotene protect against lung cancer. To large randomized preventive trials being conducted in smokers and that found opposite results. So that's say about that relevance of confoundings over there. So the first, as Akash say, that the importance of the study design. So the smoking and lung cancer could be seen by Dole and Hill study, whereas these ATBC and CARET study could show us the importance of the confounding over there. And then the recently this bevacizumab and breast cancer, that was also conducted on Avastin in breast cancer, and that's basically initially approved in 2008. Then said the tumor took about 5.5 months for longer to grow, but later trial could not confirm it. Patient did not live longer, and that's basically demerits or having sample size or endpoint issue. And then finally, Akash, Stanford
Yeah.
transplant. What is that?
So it's about the heart transplant disease, where the transplants of hearts were made in this study. So the patients who received the heart transplant appeared to be living far longer, but the thing was, until someone noticed you must survive long enough to have for a donor heart to arrive. So it was like the waiting period in to have to get a transplant was so much high that the transplants were reducing. Okay,
Yeah.
so that's what the survey this study did.
Yeah. So these are the nutshell, these four kind of context we need to keep it in mind about the design, about the confounding, about figure it out the endpoint, and the timing trap over there. So based upon that, we will having some dashboard, and you will go explore the dashboard in today's session. And there are many things in the dashboard. We don't know that everything we could cover it or not, but you can easily do at your own pace time, use that dashboard and see how things are going on. This is the dashboard link. If you open through your mobile, that's you can definitely go with that. Otherwise, let me make it little better so you can see and make the changes. Sorry. So could you if you go with this link, shortcut short url.at/jz73t1, so we can go with that. We will be exploring that dashboard help on that. Okay, so let's go with that. What we are going to have, so with this GSP, it's basically say about what is good statistical practice, and it said that set of habits that makes that number in a study trustworthy, and question fixed in advance. So when we are going to plan a conduct a study, statistics comes later, but before that we have to figure it out what we are going to ask, what study design are going to have, and then what would that distort the answer and reporting the complete enough for someone else to judge. So in plain word, planning the study properly and describing honestly what you did and what could give gone wrong, that's in nutshell is called good statistical practice. You might by hear this, if you want to conduct any study, you have to have this practice with this good clinical practice, that is called good GCP. Similarly, GSP stand with the good statistical practice, and that need to be implemented irrespective of it is done with clinical trial and non-clinical trial. Everywhere it is very much relevant, and they are the biostatistics and study design. These two endpoint, two portions go hands in hand. One is about these maths that makes sense of the patient data, whereas study designs tend to shape the study, decide before it starts. And why it is required, but a weak design cannot be skewed by a clever analysis afterward. So almost every things that goes wrong in cancer research or any medical research was decided before the first patient was enrolled, which is why the whole session is about the design. So we will go through today about this design part. And before design part, we split with some preliminary terminology, some definitions, and Akash will go with that definitions, follow with that. Akash.
Yeah. So this is all about the terminologies that we use in clinical study design to have a better knowledge of how my design is going to be, right? So we should be knowing this some terms, and we should have particular answer to this, right? First is the population. Okay, which population you are going to examine your trial on, right, or design on? The whole group of people you want in your conclusion to apply. For example, everyone in India with operator stage 3 bowel cancer. Okay, so your treatment is going to work or not work on stage 3 bowel cancer. So these are your population or the cohort, right? We need to understand this, and you need to outline this and take this kind of patients, right? Another is the sample. The patients actually,
Maybe populations mean it's called about the population of concern.
yeah.
So when you are talking about cancer, bowel cancer patients or breast cancer patients, population is not the general populations or Indian population or any country population. It's a population about specific type of cancer, bowel cancers or breast cancer. That is our population of concern.
Sir, can you full screen your PPT? Yeah. Not
I
this one.
am trying to, but somehow it's get distorted. See, is it okay now? Could you see it?
We are seeing the smaller version only, but
Okay,
if
let
it is
me.
fine, we can continue with this.
Okay. Hmm. Let me try it again. Now is it fine?
Uh, no. Yeah, it is now visible in full screen.
Fine? Okay, okay.
Hello,
Yeah. Yes.
Correct.
hello. Good morning, sir, and good morning, everyone. Sir, we have talked about two cancer, sir. Any physical appearance that we know about that person causes go for in future cancer, like a red spot and black spot in neck and any parts that have no to this person have go through like causes to cancer in future.
Are you saying about in terms of the population definition?
No, no, sir. Actually, I am today new join, and then my question is, any physical appearance like black spot and anything that have no to this person have go to future in cancer that have no about because many population have like a poverty region.
Yes. So no, unless and until it is been defined by biopsy or any medical diagnosis tool, that is the malignancy is there. It's we can't call them as a specific cancer patients. By looking some spot or something, it's not good to say as a cancer unless and until it's been defined by pathologists or clinicians. It's a cancer.
Or by
Okay,
or
sir.
unless it's medically examined.
Yes.
Okay, 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 sir. Thank you, sir.
So yeah, so we are talking about the population. So population of concern is that every individuals. It's not all means entire population. It's a populations of concern. So person with specific type of cancer. So in a if you talk about the bowel cancer, how many bowel cancer patients are there in India? Maybe 10,000 patients at a time. So that is our population of bowel cancer. So then yeah, so then sample Akash.
Yeah. So this is what the populate our study is going to benefit to population of some type of patients. So in clinical trials, what we are doing, we are taking some samples, right? We are drawing some sample from this population, like bowel stage 3 bowel cancer patients across India. We cannot go in whole India and take the patients, right? So for a tertiary cancer hospital, patients coming to it might not be the whole population of those studies, but a sample of those disease population coming to this hospital. So, so we draw basically a sample on which this study or trial is conducted, which later on answers the question for the population in that disease itself. So that is what we term it as sample of the study. Next comes is the exposure. As we all know, what is going to be the exposure? It is the treat. In some clinical trials, it is going to be a treatment which you are going to give based on which you are going to seek the outcome. But in disease scenario, it is going also going to be some kind of mutations they are having, some kind of habitual habits that they are having, like smoking or something, because of which the disease has occurred or something. So exposure is based upon your study design can be changed or considered as different. Why? Because in clinical trials or something, you are exposing to certain treatment and then seeing their outcomes. to generate a causal relationship or something. In in cohort studies or population-based studies where you are seeing for this some kind of disease or something, and you are understanding their exposures to smoking, to populated area, to some kind of inherited diseases, or some kind of mutations happening inside them due to some environmental issues or something, and developing those diseases. So this is what exposure is means as. Then the outcome, as we all know, if there is going to be a treatment or something, there is going to be an outcome. So it's an event basically of get disease being cured, whether the disease is increasing in terms of we can say like getting good response, bad response, patient having death, having recurrent diseases, the tumor is shrinkaging, which is good thing, or any kind of symptoms they are showing from their body after being in the treatment, or if in a cohort study or case control studies or cross-sectional studies, there is the outcome is basically not a treatment-based outcome, but an exposure-based outcome. Okay. Then comes a comparison group. So when you are going to do an RCT or something, you are going to have an comparison group as well, right? So we are look for population-based study, for example, case control studies on everything. We might say the exposure group is what of interest you have, like people having smoking. What is the risk of developing lung cancer? The comparator group would be people not smoking. What is the rate of lung cancer, right? For clinical trials, it would be like experimental treatment you are giving and what is the comparator control arm. Okay. So then it is easy to establish some efficacy and relative risk when you have some comparison group. So we have to define a comparison group. Is it required in your study? Not required? That is another question. But if it is, then you have to define your comparison group as well. Then the follow-up. So even to have a response, a patient needs to be in certain follow-up, right? Given some treatment, after 3 months, 6 months, you are going to assess their responses. Okay, so we need to define the follow-up correctly, and that follow-up plays a very important role to understand the endpoint and the mathematical distribution to analyze it as well. So, period over which a patient is observed after entering the study, and then act of observing them. It is considered as the follow-up. We can have 1, 2. In some trials, we can see like patient are followed for 3 years, 6 years to understand their quality of life after completing the treatment in the trial, new treatment, which plays very important role in clinical studies as well. So these are some definitions that we need to understand while developing any clinical study, and understanding the statistics behind this clinical study, which is way more the aim of this session. Okay.
Thanks. So basically, there are two components. One is this: to whom we are calling, to whom we are nurturing. That is basically population and sample. Populations that individuals will dealing with, type of individuals, and sample we are basically going to handle them. So see, populations and sample, there is a relation. So sample is a subgroup of a population. Then comes two component, that what we are looking for, whom we are looking for, population through sample. What we are looking for, we are looking for exposure and outcome. What is exposure? That is having impact, like smoking, genetic importance, drug, whatever it is. So these influencing factors that's making impact on that. Basically all are not going to get the cancer, and all people don't have, even they are having cancer, they don't have this exactly the same type of cancer or same level of cancer. So basically that's been exposure over there. And what is the outcome, what we are going to measure it? So that is basically that, event rate, cancer, death, recurrence, that is the two components. So exposure and outcome, so that's why I put it in different color, so violet color. So that's the second point, type of things. And third thing is that what we are comparing and how we are comparing. So, and because without having the comparison we can't make these conclusions, because we have to have two groups. And there is a some, how we can say that light is there, because there is a dark, that's why we can say light. We can say that this is white or black because there is a comparison over there. Based on comparing the black, we can say this is white or other color. So that's the comparison always stand over there. And then how we are going to have either with it one time point measurement or follow-up time point of measurement. So that these are the two additional component need to be keep it in mind. So now let's go for next slide. Yeah, so the point is that name here the exposure and outcome from here. Among 900 women treated for early breast cancer, we examined whether those who worked at least 4 hours a week were less likely to have recurrence within 5 years. So these were breast cancer patients. They were treated in different type of therapy. We are not talking about that, but we are having additional component given, that is a 4 hours of exercise in a week, and we are trying to see them for 5 years to see that they are having recurrence, means again recurrence means again breast cancer occur or not. So now question is that what is the exposure here and what is the outcome here? Early breast cancer, working 4 hours a week, recurrence within 5 years on the 900 women. Anyone could like to give any answers voluntarily? That would be really appreciated.
One can put in chat or unmute and answer as well. We are
Just
happy to
exposure
have
is
a conversation.
working 4 hours a week,
Okay.
and the outcome is the recurrence within 5 years.
Perfect. So that's very clearly defined, and that's need to be keep it in very nicely clearly stated where we are going to make the proposal and place to work on that. Perfect. Go to next. So this is now once you are having this exposure and outcome answer. So exposure is B and outcome is C. Then population is basically women treated with early breast cancer and comparison group who worked less than 4 hours a week without, with nobody allocated them. So women maybe less than 4 hours or no works versus 4 hours in a week. That's basically happening over there. Akash, would you like to touch now?
Yes, sir. So, as we saw, like what is going to be the exposure and what is going to be the outcome. Okay. So, walking was considered as the exposure, and the recurrence which we see was considered as the outcome, right? Which was a very very clear in this. So the population women treated for early breast cancer, the whole population was women treated with breast cancer, and the group conclusion is meant to describe. Comparison group here was women who walked less than 4 hours a week. So as compared to women who walk more than 4 hours a week, and they
Right.
did a comparison whether the
Yeah.
recurrence is having more or not. You can consider for now recurrence as yes or no, and we can just talk about it in percentage. So now that we know that we said in women who are walking for less than 4 hours, the recurrence rate is high, right? Maybe 60%. And for the women who are walking more than 4 hours, the recurrence rate is low, which is, let's consider 50%, not that much less, right? So 10% difference. So women who are walking less have 10% higher recurrence rate than that of women's
I
walking more
changed
than
my slide. Could
4
you
hours.
not see?
Yes, sir. So I was just making an example related one. So
Okay.
here the percentage what you considered, you can consider it as prevalence, right? You can consider it as percentage of recurrence happening, which is normal proportion. Okay. Incidence, we cannot call it as incidence, okay, because these are not the new cases arising in a group over a period of time. So incidence is considered as what? When we start from some particular time, say time 0, and cases are coming in, okay, and the population also number keeps on increasing over time, right? So over the
Yes.
time, what is
We
the
like to hold it, Akash. So
okay?
basically, let's get the clarity on this aspect. The context
Okay,
of calculating prevalence, incidence, risks, relative ratio, and absolute difference. Then it might be much more easy to explain.
indeed.
So once we are talking about prevalence and incidence, we are going to have much more, helicopter view of the population. So basically, among the population, we are talking how many people are having this issue, like cancer is having, like diabetes is having. So we are not in a pace where we are saying about the treatment effect comparison and trial comparison. No, so we are not. We are trying to say the assess that overall situation. So in that context, prevalence and incidence works very well. And prevalence is by and large is about uh, percentage, and similarly incidence is also by and large in percentage, but there is a very thin difference between calculating prevalence and incidence. Prevalence, keep on saying, considers this time effect over there. For example, if you say that 2022, what is the prevalence of breast cancer, so we are going to consider 2000 in 2022, uh, all existing breast cancer, that's been who was diagnosed and still alive with breast cancer in 2015, 16, and maybe 2010, still having breast cancer. If somebody still, if they are recovered, if they recovered, there is not any problem, but they are not going to consider. But if they are still in breast cancer, those who are diagnosed 2010, 11, and still in 2022 and having with breast cancer, then we will consider them for calculating prevalence. Whereas incidence is basically in 2022, how many new patients with breast cancer occurred. So there is not any function of T being considered. So that is a different way. But in nutshell, both are basically calculating in a percentage. Prevalence is going to go higher because it is going to be more number of patients, but simultaneously it is also going to consider more number of people over there. Whereas incidence only going to consider the in particular year number of new cases. Now the risk ratio, over to Akash, how we are going to have risk ratio, Akash.
So risk ratio basically means is the risk calculation as compared to a comparator group. Okay. So now we have here the comparator group as 4 hours, more than 4 hours walking, right? As compared to that, what is the risk of having disease in patients walking less than 4 hours? That is kind of a risk ratio we make it, where one is considered to be null risk, where there is no risk, both the groups are equivalent. Now that we are saying as compared to good group, which is our more than 4 hours walking, what is the risk in the bad group, which is less than 4 hours of walking? And that would show us number more than one. And number more than one means increased risk. Okay. And if you are going to see it in other way, like what is the risk in women's walking more than 4 hours, which is a good group, as compared to the women's walking less than 4 hours, which is bad group. Okay, then you will get a number less than one, which shows a reduced risk. So the relative risk or the risk ratio is used to compare the risk with a comparator group and to put it in the results. For example, here a ratio of 1 means no difference, which is equivalent, both groups are equivalent. 2 means the risk has increased twice in the bad group. If we say the risk in less than 4 hours walking group is 2 as compared to more than 4 hours walking group, which is higher the risk twice. Suppose if there we say it is 0.5, then it means that risk in women's, which is good group, walking more than 4 hours a week is uh, half than that of the risk in the bad group. So risk ratio always it has one as in between. If you go towards the right side, it is increased risk. You go towards the left side, it is decreased risk. You have to keep a comparator, maybe a control we can say, or a comparator with reference to which we calculate the risk. Okay, so it is a bit complicated, but yeah, you will see a lot of results being represented as risk ratio, odds ratio, relative risk, which means that higher the number, more than one, the risk is increasing. Number lower than zero, risk is decreasing. Lower than one towards zero. Okay, then is the absolute difference. Absolute difference is nothing but change in percentage, change in mean, change in numbers. Okay, so here we say risk has increased by 10%, right? And people walking, women's walking more than 4 hours have 50% recurrence. Women walking less than 4 hours have 60% recurrence. The difference basic is 10%. That is we define as the absolute difference between two groups.
Not
Okay.
only that, now let's see the context of using this risk ratio and absolute difference. As I mentioned, that where to go with the prevalence of the incidence, it can be done much more on the out of clinical trial context. So in the population level, overall summary we want to go. But the risk and risk ratio both can be applied. Even absolute difference, these three component could be applied in both contexts, clinical trial context, or once you are having this specific trial group of patient cohort, you are observing them for certain period, doing some experiment, seeing that the if you give the exercise how things are going on, if you don't give exercise how things are going on, all sort of things. Similarly, in if you in general in the population, if you want to see that if they are having smoking, what is the risk of having cancer, if they don't smoke, what is the risk of having cancer, and that is basically risk calculations. And then we can get the risk ratio by having the relative risk by those are having cancer with smoking and not having cancer without smoking, what's that different, what's the ratio of that. So that's why the population level we can calculate risk ratio. Similarly, cancer with smoking, cancer without smoking, that difference could be calculated also in absolute difference. So these tools, these risk ratio, absolute difference, these can be adopted in various places, and that's basically going to show in this population level data the strategy standpoint as well as your clinical outcomes data standpoint. Both place we can adopt it.
And this is very important to understand before designing a study, because we need to know what is going to be your endpoint. It's an absolute difference, it's a risk ratio, it's base prevalence, it's incidence, what it is your endpoint based upon your clinical question. Hence, you should know this.
Yes.
Second,
So having this prevalence and incidence could be considered, but in general, it's taken quite while to conduct trials. But as you said, Akash, so because it's having impact. So if you are having primary endpoint is look upon the risk or risk ratio or absolute difference, then your sample size, your study design, everything been formulated in that manner, and that makes much more sensible to consider before study what is your objective, what you are going to see over there. Next, go to the next slide, and there are 1 2 by 2 table. What is the risk recurrence in each group, what is the risk ratio, what is the absolute difference in percentage point, and how many patients we would need the new drug for one of them to avoid recurrence. So risk is that number who had the event. So could we find out what is the risk over here? So recurred by 3 years. So basically that is this reason or occurrence of the event. So if you see that out of 400 people, 200 and 200 patients, so 100 were having recurred by 3 years. So recurrence is basically called it as a risk. So 100 out of 400 is basically risk. Now this 100 could be split between new drug and standard drug, that is 40 out of 200 and 60 out of 200. So if you talk about in drug level, risk is basically 400. For new drug it is 440 by 200, and for standard treatment is 60 by 200. Whereas risk ratio, that is 40 by 200 divided by 60 by 200, that is basically going to go calculate this risk ratio. And in case of absolute difference, 40 divided by 200 minus 60 divided by 200, that would be our risk ratio, absolute difference. Yeah, please. Hello, anyone saying anything? Akash, would you like to add anything?
Uh, no, sir. But yeah, this kind of table will help you. So, for example, if you are doing any design or study or something, what you are going to say is, I am going to have total of 400 patients, of which I will allocate 200 into standard, 200 into new. And now, what I am going to be interested of to see out of this 200, how many have developed, recurred over some time, and in this group, how many. So we can nearly see that in this group it is 40, which is 20%, and in this group it is 60, which is 30%. So we can ideally see that the recurrence rate has decreased in standard new group as compared to the standard group. Ideally, that is my one of the question which is now answered. Further, you can calculate this percentage and the difference, which is 30% and 30% and 20%, and you can say that it is 10% reduced recurrence because of the new drug. Okay, that is what you are going to answer from this. Further, you can make it into more complex outcome to have its more importance, because you are already having a comparator group. Why not interpret it in risk format, right? So then we can go for individual group risk, which is the percentages we reported. Then the risk ratio, like as compared to the standard treatment, what is the risk of recurrence in new? Or it is going to be less than zero as compared to the uh, new one. What is the risk in standard treatment? It is going to be high. So that's how the risk ratio is going to tell about more information in a comparative manner. Hence, for a phase 2 study or phase 3 study or any kind of population based cross sectional cohort study, you have a binary endpoint. This is the best way to report it. It will give
Perfect.
more answers to your questions for primary.
Let's go for next one. So
Yeah.
these are just some example you are already explained. We are not going to go with this.
Yeah.
So this is basically calculations on that. And then we'll be having, this is basically this very short slide one, the time to event. So survival time, censoring time, median survival, and survival curve. And these are basically, once we are having follow-up study, we are following a patient for certain time point, and then we are going to measure that how many are going to have event like recurrence or not. In that context, survival time is very much relevant. And and then these many patients you are not going to follow because they may drop out from your study, and you never know what happened to them. That's basically raised as a censoring called as a censor. So it's completely different. That's the word called censoring that used generally for this movie that censored or not. So that's completely different story together. And then what time point or the median durations we are talking about for the follow-up, that is called median survival. And then we are going to have survival curve. So don't worry, we will touch very thoroughly this context for upcoming sessions about the survival time point, censoring, and median survival. And definitely we are going to give much more attention on that, and that's very much relevant towards cancer context. So in nutshell, how long we are going to conduct, that is called survival time. How long, what we last list this far, no further information is that is basically censoring. And the point at which half the group has had an event, it is called median survival. And a picture to how the groups has been changed over time, that is basically survival curve. We are going directly with, we are not touch now this one. We will go with, before start touch study design, I try to go with dashboard. So let me stop sharing it, and then I will go into for dashboard. Okay.
Do you guys have any questions?
Anyone
Like,
having
so
any
one we
point?
had is when are we using RR and risk? One question we received in common.
When we are
When we should be using RR and when should we use risk?
risk difference and Okay, risk difference and RR stand for relative risk.
Yes.
See, there is not any specific condition where you can or cannot use a risk difference or relative risk. It's based upon your, to be honest, see, in any study where relative risk could be adopted, the same study risk difference could also be calculated. Risk difference, I would say, give you much more rough idea about the comparison, but relative risks give you much more better idea about the comparison, that I can say. But in terms of the calculations, wherever you are going to use risk difference or relative risk, both can be adopted at the same times. In terms of the study design, is it a case control study, is it a cross sectional study, or is it a follow up study, that need to be considered in mind before adopting either risk difference or relative risk. That is a very crucial, which context you are using risk difference or relative risk. Okay, and other than that, I think any place both can be adopted. Whenever one can be adapted, the same place another could be adapted.
So another question is there.
Hmm.
He has gone through a paper which is doing Cox regression, but presents RR instead of HR. It is incorrect,
Okay,
right?
definitely. So that's incorrect. So if you are, if they're saying they are using Cox regressions model, then they are bound to give that estimate throughout hazard ratio, not by relative risks. The first point. But relative risks, what it is? Let's say relative risk is risks of one group with respect to another group. It could happen, I'm not completely discarding that uses of relative risk in this context. It could happen, you have to look upon very thoroughly after calculating hazard ratio, if they make the derived variable as relative risk. This means they calculated hazard ratio because they say that we are using Cox regression. Using Cox regression, they got the hazard ratio, but after calculating hazard ratio, using the hazard ratio to go for relative risk, that might happen. So here, the relative risk is not calculated directly from the data; it was calculated through hazard ratio. If that is the case, then it's not wrong. It could be happen. It's correct way. Other than that, if they use Cox PH model and they document it by relative breaks without being any derivation, then it is wrong. I hope I could give the answer, make the sense on that. Okay, so could you go with the next dashboard one?
Yes, sir.
Let yes. So that link we have seen earlier, there is a dashboard, and we will see some question and answer sort of things. So let's say registry comparison of resections versus no resections. We identify all patients diagnosed with pancreatic cancer in the state registry between 15 to 22 and compare survival in those who did and didn't undergo resections. So, and the exposure is those who are treated, and then after having exposure treatment, they develop the outcome. Who develops the outcome, and non-exposure, those who are not treated, and then who develops the outcome. So that is this starting up the cohort follow-up study, and then we see that after certain time what happened. And then question is that what to look at. The arrow runs forward and then fixed effects. So question is that who decided which patient had surgery, what is the design call, and name of the reason the two groups differed before any surgery happened. The question is that who decide which patient had surgery, what would be? let's go again the point. We identify all patients diagnosed with pancreatic cancer in state registry and compared survival, who did and did not undergo resection or surgery. So, who decide which patient had surgery? Is it are you going to decide the patient would be having surgery in this study or not? That is the first question. Obviously, we are not, because we are going retrospective data. So these are already predefined. And that, what is that design called? It is a basically retrospective study design and retrospective cohort. So nobody allocated anything, because surgeon and patient had those decision in clinic years before this study existed. Researcher read this record afterwards. So, and then what is the design called? It is a retrospective study design. And name one reason the two groups differ before any surgery happened. These patients groups were never comparable. Patients are offered resection when the tumor is localized, when they are fit enough for major surgery, and when there are no metastasis. Every one of these also predict longer survival as usual. How it should have been done or said? The honest sentence is that patient who underwent resection lived longer than those who didn't. So how much of that operation, how much was being the kind of patient who is offered an operation cannot be separated from this data. So that's that limitations of the retrospective data is having. So we can't make that neck to neck comparison. We can't say that because it's already been there. You are just checking the data and trying to figure it out what is there and what not, and based on that we are calculating. But one good point is that this is a big data. You are having huge number of patients of observations over there, and based on that we are trying to look upon. Would you touch next point, Akash?
Yes, sir.
Yeah.
So this is another where the consecutive patients attending during the March were offered a swab HPV testing, and the proportions testing positive was recorded. Okay, so it is what kind of study design do we feel it should be? Can anyone tell? Uh, can we hear any answer? So can you go to the question again, like if anyone? So here it is consecutive patients attending the head and neck clinic during March were offered a swab HPV testing, and the proportion testing positive was recorded. Okay. So how do we consider it?
No, this is experimental.
Cross-sectional.
Cross-sectional, one said experimental. Okay.
Or it can be cohort.
Cohort. Yeah. So why we received one as cross-sectional, one as cohort, and one is RCT. So can we have a reason behind all these answers? Like, can anyone tell one reason behind?
Because we are looking at a particular time point, that is March, so
Yeah.
it can be cross-sectional.
Okay. So in you mean like in March month, we are just having these patients and doing this
Yes,
HPV testing and
we
seeing
want
what
to
is going to be
understand
the outcome.
yes,
Yeah.
what is the percentage of
Very
positivity?
good. Yeah.
So the first is it an experimental study or observational study? What is the answer? You
Observational
will say
test.
it's observational,
Observation.
cross-sectional,
Yes.
right? Okay, any other justification for RCT or
There are
cohort?
three questions. The researcher
I think
actively did something. Does it make the experimental? What is the design call? And what can be the study tell you? And what can it not? Yes, someone saying
Someone was,
something.
yeah.
it is experimental because there was an HPV testing involved in this. So this was a randomized trial.
Okay. Okay.
Okay. But we do not see any kind of comparator testing there, right? So they offered swab. Okay. During March, we also were offered a swab for
I think there is a confusion. So experimental means we are not testing that. We never say that we are testing HPV. That's why it's experimental. Experimental means that there is an experimental arm, there is a dedicated arm, and there is a reference arm. Thereafter, we are going to make the comparison. That's what it stand with. So, yeah, I think that's the point. So it would not be. So should we go with answer? Unlock the answer now.
Yes, sir.
So let's see what's the answer now.
So the researchers took swabs, so it feels like active, but they did not allocate any treatment, right? So nothing about what is another treatment. Performing a test is not the same as deciding who gets the treatment. So exposure and outcome was captured. So this is a cross-sectional by definition, that they are just saying we are giving HPV testing and seeing what is the result going to be, positive or negative. And what they are going to calculate is a proportion, or we may say prevalence of percentages positive.
Yeah.
So it can be considered as cross-sectional study.
Exactly. So go to next point then.
Yes, sir.
Yeah. So this is another point. Interviewing patient who already have the cancer. Patient admitted with carcinoma for lung across 20 London hospital were interviewed about their smoking history. The same number of patients of similar age and sex admitted for other condition were interviewed identically. So then it's a direction that cases, and then we are trying to figure it out their past exposure. In control also, they are trying to find out their past exposure. Where does this study start, with the exposure or with the outcome? First question. Second question is that what is the design call and why did they choose it, and what is the single hardest part of running it as well? Any potential answer?
First comes the outcome, and then we retrospectively look at the exposure.
Yes.
This design is called case control study because of the direction of exposure.
Mm-hmm. Okay.
Because it is a retrospective study, it is very hard to collect information, complete information.
Hmm. So that is the third point, is this what information would be very hard to collect here precisely? If you say what is the single hardest part of running it as well, or hardest part of collecting information here? Because upfront we can see the patients are having control or not, or cases or not. What could be this point of having hardest part? Hardest part is that it is very difficult to get what sort of exposure was there, because for us what we eat yesterday or day before yesterday is very difficult to recall and say. Forget about 3 years back or 4 years back what we use in particular day. So similarly, last backward, what we are having exposure, that is really difficult to measure and calculate. Somebody was saying in rural area, somebody in urban area, somebody was having exposure with occupation, somebody was having not exposure. So these are quite tricky part, and recall recall bias is definitely there. People get forget. Majority thing is that people not documented everything and people get forget everything, and in that context is very difficult to say on that. So that is the hardest part. Yeah. Yeah, as you say correctly, it's an observational case control study. It start with the outcome and look backward. Absolutely correct. Why not the following patient, choosing the control, and that the hardest part is memory in weak point. So patient told they have lung cancer, such the past of explanation of the harder than patient admitted with the fracture. So this is called recoil bias, and it inflated any exposure difference over there. Okay. Could we go to the next one?
So here we are doing is interviewing the patient, 40,000, sorry, I read the same one. So we have every doctor on the British Medical Register was written to and asked what they smoked. So those who replied were followed for their rest of their lives and their cause of death recorded. So it's kind of
Yeah.
that they are noting the exposures and then who develops what, if they are not or if they are doing something.
Yes.
So what kind of
So
design it can be?
so point is that where does this study start? What can it measure that case control study cannot? And why was this study that convinced the world? Any attempt would be really appreciated.
So it's an exposed and not exposed, but not allocated, right?
Yeah, not allocated.
So what is the guess, guys?
Nowadays we call it this kind of study in fashion terminology. We call it as a pragmatic trial. But yeah. Where does the study design start? Anyone, please? Nikita, you are answering earlier questions. So if you would like to answer this question as well. No? So it's a follow-up study, observationals, a prospective cohort study. It start at the exposure, and doctors were sorted by what they smoked before anybody knew who could develop cancer. So ordering is the whole point. It delivers real risks. Exposure clearly came first here, and what it still cannot give, so that is this cannot convince the world. Doctors were not allocated to smoke, so it was not properly randomized. Smoker differ from non-smoker in other way too, so there are many basic reasoning for that, so that's not been well controlled, well balanced. Like this case, rest of the size of the effect, dose response relation, and this data consistency. So these are the quite limitation would be there for where you are going for prospective observational prospective study. But here, in this context, we don't have any intervention. One good point is that there could be n number of imbalancing in this sort of experiment, sort of design, but those can be handled by creating different subgroups, balancing data. And the good point is that generally cohort study, people never plan to have this sort of study. They naturally keep on moving and people just go and collect data. So there is not any intention started with this for this cohort study we will be going forward and collect data. No, not naturally data being captured, and after certain time people see what been happen. So in that context, since the data being captured naturally, so it is a very high chance that there is a good amount of data. Means sample size in both case, exposure and non-exposed case, are quite high. Since these are quite high, so we are always in a better positioning to do different subgroup wise analysis, and that's why we can do many permutation combinations and balancing over there. However, in normal terminology, balancing randomizations never been done, so that could be an imbalance comparison on that ground. Otherwise, if you go for subgroup or data adjustment, like variable adjustment through modeling, then definitely we can handle it.
So is that modeling or variable adjustment meant by matching the exposed and non-exposed
Yes,
based upon
exactly.
some criteria?
Yeah.
That's what I understood. Yeah, so these designs might seem to be very simple, but these are future designs as well, we call further, like because a lot of assets of group analysis, matched pair analysis, and more evidences could be generated with advanced things, but we should be knowing how it can be taken further, right? So that's why it is very important to understand this. Thank you, sir, for your
Correct.
detail.
Go for next one.
Yeah. So we described 3 men employed at the same polyvinyl chloride plant who represented within 4 years with angiosarcoma of the liver, a tumor of which fewer than 30 cases are recorded annually worldwide. Okay,
For
so
type 2, it should be systematic review and meta-analysis first. Yeah.
so I didn't got you, sir. Okay.
No, the first portion is the systematic review and meta-analysis.
Yeah, okay. You are highlighting. Okay. So report in 1974, it led to the recognition of vinyl chloride as human carcinogen. Okay, uh, so we had the hierarchy here. So in cases where the disease rate is very low, how it has to be summarized. So
Yeah.
what kind of way it should be opted for? So you all being clinicians and medical people, you'll be knowing what in such cases how you should be planning some kind of evidence generation method. So what would be the answer you would be looking for doing this?
So yeah, again,
So one
this is the
is
yeah.
so a case report or case series, cross-sectional studies, case control studies, cohort studies, randomized trial, and systematic review and meta-analysis. Ideally, as we laid down all the designs in all our examples, this is the hierarchy of the evidence which is treated in real life when you do some trials or anything. So case reporters, case series are considered at the least importance based upon the evidence hierarchy, then cross-sectional, then case control studies, cohort studies, randomized control trials. This is the utmost design level, trial level, population level, subject level trial considered as the highest hierarchy. Then comes is the systematic review and meta-analysis, where you are just meta-analyzing all this studies or designs in one umbrella. Okay.
So
So
again, to add you something. So when you are talk about case report and case series, we are going to deal with one and two individuals, and you are experiencing and explaining their experience in a paper format. That's all about. So there is not any sample size being added over there. No proper study design is required. Only you are looking about the patient's experience and explaining. That's why it comes completely first stage of research, and that from that generally many people started working on that to started with the case report and case series, followed by cross sectional study. So you just going and surveying the individuals, you never look upon the study design much more, never look about the follow up, never look about the randomization, just go and do the survey and try to figure it out. That's why followed by case report, cross sectional survey comes. And thereafter we are having case control, because we are going much more in deeper way. So we are trying to see that individuals are having problem and not having problem, and then going back to what is their exposure level. Still it is a better methods as compared to cross sectional, because in cross sectional just we are now asking them the scenario, but in case control we are going back and trying to understand guess what was their reason exposure and that sort of thing. That's why it is giving, since time is back time or retrospective time is added, that's why it is much more better as a case control, as a study design, followed by cohort. So where you are already planned everything properly, and then you keep on going moving forward with these individuals for longer time. And generally all the randomized control trial, clinical trial, by and large comes under the cohort study. So basically we are defining in group of individual, and we are keep on following them certain years or months. That's much more better, because we are following them for a longer time, we are having very good sense what the things are going over there, and simultaneously we are having randomizations, balancing everything done. That's why the core study some extent. And then we are having the randomized control trial, where we are started the study with itself with the randomizations. So in cohort we are having the flexibility without doing the randomizations, but in randomized control trial we are bound to go with selecting patients by randomized manner. And once multiple studies, multiple RCTs been done, multiple places across globe, then we consolidate those studies result into a single manuscript, and that is nothing but systematic review and meta-analysis. That's where it is stand. I'll touch here this the final questions, and there are many things over there. Let's say about observational, a case series, it proves nothing and then it change. No denominator, no comparison. And why it is still matter? The tumor is on rare, so that cases in one place is not possible to coincidence. So the right next, core studies for chemical worker, the regulatory exposure limit, the case series asks a question of other design. So I think we already touch upon on that. Okay, with that, any point, any confusions or anything you want to add it over here? Any of you? Please feel free. We're having some question and answer now
or
session.
or anyone using such kind of designs in their experience now and have anything to share?
Anyway, we are having so many. We already shared with you
Yeah.
the link. We are having many things here: design, time point, number, timesheet. Please go at your pace and check with that. Yeah, somebody was saying anything? Any question and answer? Any comments?
Sir, I might ask one HBCH Ankush, like, are you working in any of this kind of study designs? I might say you might be working on some RCTs. Can you share one of your experience from RCT working there?
Ankush?
हाँ
Yeah.
sir.
Yeah.
Sir, in RCTs we do some stratification factors and some calculate some sample size for RCT studies. But initially we get sample size for one particular strata, and some stratas are totally blank. So in these cases, how to deal with these cases?
So basically you are conducting a RCT, and in that RCT you are already creating some randomized number, and then once you roll out with the randomized number, you see overall the comparison is going to come, but after that both the arm don't have some specific subgroups, or in one arm completely zero subgroups. Is it correct?
Yes, sir.
Yeah. So let's give in an example like ECOG status. ECOG is having 0 and 1 and more than or equals to 2. So there could be ECOG could be differentiated into two factor like 0 and 1 and more than equals to 2. Now, with this standpoint, but your randomization RCT is not for ECOG. It was for like comparison arm and not comparison arm. We are having randomizations, and there we are conducting it study. So we are having either 1 and 2, whatever it is. But once you conduct that, then you see that one arm don't have more than 2 ECOG group, or another arm don't have 0 and 1 ECOG group, and that's the problem comes over there. So to have it, what we can do, we have to identify, not with ECOG, we have to identify a couple of other factors. Those are really relevant to make the treatment effect changes on that, like ECOG, like disease status, like stage 3 or stage 4 or something else. Once we are identifying those very crucial relevant factor, after that we're trying to make, it's called block randomized design. So we are splitting the entire blocks randomizations into small blocks, and from the each blocks we are trying to ensure that once the first blocks of the randomizations been done, there is a good number of the strata representations. That's where it been handled.
Yes, sir. If we have 4 strata and 2, 3 are completed and one strata is totally blank, in these cases we have to stop the randomization for the strata, those who completed the sample size.
Could you repeat again?
Means, sir, we have total 4 stratum. So
Yes.
out of these, 2 complete the sample size of that stratum, and one has nearly half, and one is totally blank. So
Yeah.
we have to stop the randomization for complete the stratum, or start?
No, that would be completely biasness. You can't stop the randomizations. No.
Yes, sir. One stratum
So
is totally blank, na, so the patients
yes,
from these groups not coming.
particular strata is blank, but you are getting the patient being enrolled for both the groups, right?
Yes, sir.
Yes. So since it's not being planned properly while you are preparing your randomization schedule, you can't change the randomizations after that. It will be biased by looking the strata. So what would happen? You keep on going on that. At the end, whatever the results are coming, you have to put it over there, and by accepting the limitation that this particular stratum was not been captured. Beyond that, rescheduling or resampling or creating re-randomization is not not correct to have it over there. And don't chase for stratum wise value, because it is already designed and many patients already been randomized with this current strategic plan. So it is not worthwhile to go with again stop and pause the randomizations and wait for stratum. No.
Yes, sir. Thank you, sir.
Okay, then should we end it here?
Sir, I have one more question. It is,
Yeah.
suppose we are design a study that will build a registry of certain cancer, then how do we decide on sample size? Generally, the paper says that we are building a registry for, let's say, for 5 years, and we recruit as many patients as we get in 5 years.
Yeah.
But is there any way to calculate sample size or define the number?
For registry?
Yes.
No. So there is, sorry. So no, for registry, sample size calculation is not at all required. Reason behind that, we are going to cover all individuals in a specific area through the registry. While we are going to consider the sample, while we are having go and collect specific individual data, but in registry, it's a cover the entire group of individuals. So there is not any piece of data you are individual you are going to collect. So that's why registry should not have any sample size calculations story over there.
And basically, if it is a multicentric study,
Mhm.
and in the protocol, what we can write if, under the sample size section?
We will say that this time point to this time point we will follow the pay individual, and we will collect from these locations, and this location how many patients been enrolled, that we will collect. So other than that, nothing is required to mention.
Okay, thank you, sir.
One second, Akash, would you like to?
Yes, sir. Uh, yeah, so we have some say, slides more on designs and everything, but we thought of making it an example manner to make it more understandable. And I hope we have answered it in some manner. So we would likely have want to have your feedbacks on this. We'll share this PPT. It has more about designs in written manner. All the slides are given there. You can go through it once and let us know. We'll share some feedback. Do let share some feedback. We have also asked anyone if you are interested in sharing some of your questions, clinical questions, or statistical work that you're working and having doubts in. We can answer those as well. We include those. Uh, Likely from start session where we were working more upon data and this test, and now we are into design, so we will gradually progress towards advancing sample size calculations and more of software related work. So but yeah, I hope you guys have got an idea about designs now for a bit, and how further we will develop some questions. So we in exercise we have some articles derived, which can be critically appraised. We'll share you all those articles with online questions. So your critical appraised answers can be recorded there and we can assess it. Not to judge you or something, but assessment in a way like you are understanding. That is the whole validation we would require. So let us know through any means. We'll share you the feedback from and that assessment as well. Appraisal. Looking forward for more such sessions. We'll be continuing this. This is only the fourth session, I guess.
Yeah.
So yeah, if you have anything to let us know, do let us know.
And thanks a lot to all participants that you encourage and raise the points and give this response.
Yeah. So we'll share this recording as well, the PPTs. Please feel free to go through the link and attempt those questions, MCQs more. Let us know if there is any doubt, and we'll share you the assessment and further feedback from us.
Thank you then.
Sure. Thank you, everyone. It will be shared on mail directly. Thank you. Thank you. Bye, guys. Thank you. Thanks, Ankush. Thank you, sir.
Thanks a lot.